I'm Shirley, a second-year medical student at NHRC. I'll be presenting our project on reducing the rate of preoperative anemia in gynecology surgery at a Northern Ontario tertiary care centre. Tara Dusick and Karen Splinter, who are part of this project, work at Health Sciences North. Dr. Splinter is a professor at NOSM, and I received a couple of summer medical student research awards from NOSM to fund my work. Patients who need gynecology surgery to address symptoms like heavy menstrual bleeding are 2 to 3 times more likely than the general population to have anemia. If a patient has anemia before surgery, they're at an increased risk of surgical complications like infections and return to the emergency department. Anemic patients are also more likely to experience delayed recovery after surgery, as well as postoperative morbidity and mortality. Anemic patients are more likely to need blood transfusions during or after surgery to replace lost blood products, which further exacerbates their risk of complications as transfusions are immunosuppressive and associated with infections, blood-borne morbidity, and increased length of hospital stay. On average, each surgical patient with anemia actually costs the healthcare system over $100 more than a patient without anemia. So, if we take the risks of preoperative anemia and blood transfusions and combine them with the shortages we have in donated blood and healthcare resources, our efforts to correct preoperative anemia are justified. Thankfully, iron deficiency anemia can be eliminated easily and cost-effectively with over-the-counter iron supplements. At Health Sciences North, there was no proven protocol to reduce the rate of preoperative anemia. Patients had preoperative blood work done at inconsistent times, often less than 1 week before surgery, and so they didn't have enough time to correct their preoperative anemia when detected. So, the aim of our study was to assess the effectiveness of a quality improvement project at eliminating preoperative anemia. In this project, the surgeon, a study nurse, and Seamless MD, which is a remote digital application that prepares patients for surgery, collaboratively ensured patients obtain blood work, ideally 4 months, but no less than 3 weeks before their surgery. If this blood work revealed that the patient had anemia, which was defined as a hemoglobin of less than 120 grams per liter, the study nurse or Seamless MD prompted the patient to take oral iron daily to correct their anemia. Then, the patient got a second set of blood work done within 3 weeks of their surgery to measure their hemoglobin again. Our primary goal was to have a 25% reduction in preoperative anemia. Our secondary goals were to reduce postoperative complications, returns to the ED after surgery, and blood transfusions. Our study consisted of a retrospective and prospective chart review. In the retrospective chart review, I looked at the charts of 255 patients who underwent elective gynecology surgery in 2022. If these patients had preoperative anemia, they weren't told to take iron. This was our control. I recorded the age of these control patients, as well as the prevalence of preoperative anemia, perioperative blood transfusions or complications, and returns to the emergency department within 30 days after surgery. In the prospective chart review, I recorded the same independent variables, but this time for 40 patients who were part of our quality improvement project, meaning they got their blood work done early and had time to take iron to correct their anemia if their hemoglobin was less than 120. This was our treatment group. We found that the prevalence of anemia decreased from 14% to 7.5%, which met our goal of a 25% reduction in preoperative anemia. Also, 3% of patients in the control group required blood transfusions, while no patients in our treatment group needed blood transfusions. However, the reduction in preoperative anemia and blood transfusions was statistically insignificant. Also, patients in the treatment group were just as likely as those in the control to visit the ED within 30 days after surgery. Interestingly, we did see a significant reduction in the number of serious surgical complications. Note that the two groups did not differ in age, so the reduction in surgical complications cannot be attributed to the treatment group being younger. In conclusion, our project led to a nearly 50% decrease in preoperative anemia and saw no need for the use of blood transfusions. While patients were still just as likely to visit the ED within 30 days after their surgery, they didn't experience any higher grade postoperative complications like surgical site infections. Possible future directions for our study include increasing the sample size of those enrolled in our quality improvement project to achieve statistical significance, determining which ED visits were specifically due to surgery, and brainstorming ways to improve patient compliance with taking iron. Thank you for listening.